Good morning, everyone. Welcome to the Orlando GI Journal Club. This is August 2nd, 2023. Our first study is from the Journal of Hepatology, and this is a randomized trial looking at high versus low target mean arterial pressure in patients with cirrhosis and septic shock. Patients with cirrhosis are in a hyperdynamic circulatory state with severe vasodilation and high cardiac output. In sepsis, systemic and splanchnic vasodilation causes venous pooling, which decreases kidney perfusion, and then vasoconstriction in the renal vascular bed. Use of vasoconstrictors counteracts vasodilation and improves renal function. So high mean arterial pressure target, so MAP of 80 plus, has been associated with improved renal outcomes in cirrhotic patients, but this has not been studied in patients with cirrhosis and septic shock. So these authors performed a randomized trial to compare high MAP versus low MAP targets in critically ill cirrhotic patients who are admitted to the ICU with septic shock. So this was a randomized trial. This was an open label study at a single tertiary care center in New Delhi, India. Patients with cirrhosis and septic shock with acute renal failure admitted to the ICU were included in the study. Patients were randomized either to the high MAP target, so 80 to 85 millimeters of mercury of MAP, versus low MAP target, 60 to 65 millimeters of mercury. MAP was maintained until reversal of shock or for 5 days, or until there was an adverse event associated with MAP, in which case they had to stop constricting medications. The primary outcome was the survival at 28 days since start of the treatment for MAP target. 75 patients were enrolled in the low MAP target group, 75 patients in the high target mean arterial pressure group. And as you can see, the mean ages were 46.7 years in the low target group, 45 years in the high target group. There were more men than women enrolled in this study. The MELD scores were 32.5 in low MAP target, 31.5 in the high MAP target group. When you're looking at the biochemical parameters in patients enrolled, the white cell count was 16.4 in the low MAP group, 18.4 in the high MAP group. The mean serum total bilirubin was 13.6 in the low MAP group, 13.9 in the high MAP group. Mean INRs 3.7 in the low MAP group versus 4.2 in the high MAP group. Causes of sepsis, most commonly pneumonia, followed by SBP, and then the less common etiology for sepsis was UTI, empyema, and then spontaneous bacteremia. So when these authors looked at the 28-day mortality, they found that there was no significant difference between the high and low MAP groups at 28 days at 65 versus 56%. Reversal of shock was achieved in 47% of the high MAP group versus 53% of the low MAP group, and acute renal failure development occurred in 45% of high versus 31% of the low MAP group. Again, there was no statistical difference between the two groups. The secondary outcome measures included recovery from acute kidney injury, which was achieved in 31% in the low MAP group versus 45% in the high MAP group when looking at intention to treat analysis. There was also no significant difference within the two groups in the need for renal replacement therapy at 53% versus 57% with p-value of 0.62. However, what was statistically different was the incidence of intradialysis hypotension, which was higher in the low-MAC group at 48% versus 12% in the high-MAC group with p-value of less than 0.001. When looking at other measures, adverse events was also significantly higher, however, in the high-MAC group at 24% versus 11% in the low-MAC group. Other secondary measures, such as the duration of mechanical ventilation, length of stay in the intensive care unit, reversal of shock at day 5, and improvement in SOFA scores at 48%, were not statistically different between the two groups. The limitations of this randomized trial is that they collected no data on echocardiographic parameters and intraarterial pressure and renal resistive index. Use of definitions proposed for acute disease quality initiative group for defining acute kidney injury recovery was used rather than complete renal recovery. The main take-home point from this randomized trial is that higher MAP strategy does not confer a survival benefit in critically ill patients with cirrhosis and septic shock, but does improve tolerance of dialysis and renal recovery. Higher adverse events indicate the need for better tools to evaluate target microcirculation pressures in these patients, however. Our next study looks at the yield of repeat endoscopy for Barrett's esophagus after normal index endoscopy. This was published in the American Journal of Gastroenterology. Incidence of esophageal cancer has increased six-fold since the 1970s, and Barrett's esophagus is the primary precursor to adenocarcinoma. Society guidelines suggest a one-time EGD for Barrett's esophagus in patients who had considered an increased risk for esophageal cancer, who are basically men who are white with symptoms of GERD. And then, if discovered, endoscopic therapy for dysplastic Barrett's or endoscopic therapy for early esophageal cancer. Evidence suggests that Barrett's esophagus develops in middle adulthood, and therefore, if EGD is performed too early, you could potentially miss Barrett's esophagus that could develop at a later age. Therefore, repeat EGD may be beneficial after a normal EGD examination, similar to repeating a colonoscopy for screening purposes in 10 years after a normal colonoscopy. So the aim of this study was to estimate the yield of repeat EGD for Barrett's esophagus or cancer at prolonged intervals after a normal index EGD. This was a retrospective study looking at using data, national database of the United States Veterans Health Administration with index EGD performed in patients who are less than 70 years old and who did not have findings of Barrett's esophagus, erosive esophagitis or esophageal cancer or G-junction cancer, who then had a repeat EGD at least 1 year later. And they identified patients who underwent index EGD between January 2003 and December 2009. And the primary outcome was to look at the incidence of new diagnosis of Barrett's esophageal cancer or G-junction cancer. So from the United States Veterans Health Administration database, they identified 467,801 patients who had an index EGD. After excluding patients who had prior Barrett's esophagitis on an ICD code that was searched for, and 3,359 patients who did have prior cancer in the esophagus, they identified 364,000 patients with normal index EGD. When they excluded around 200,000 people, patients who did not have repeat EGD, they identified 166,000 patients who did undergo repeat EGD. After finally excluding patients who had EGD within 1 year of index endoscopy, who had a new diagnosis of Barrett's esophagitis between index and repeat EGD, and 16,000 patients who were more than 70 years old at the time of index endoscopy. 71,000 patients comprised the final cohort. Of these 71,000 patients, 4,088 patients were coded as having new Barrett's esophagus esophageal cancer or G-junction cancer. They then randomly selected 411 patients for chart review, for manual chart review. And out of these 411 patients, actually only 96 patients had true new Barrett's or true new cancer. So what these patients then did was these authors basically looked for coding that was entered in these patients who had an index EGD, who then had a repeat EGD more than a year later, and then who were coded as having new Barrett's, new esophageal cancer, or new G-junction cancer. And they looked for factors associated with new Barrett's esophageal cancer after repeat EGD by running a logistic regression analysis. And they found that when looking at these various factors, when they were adjusted for baseline characteristics, they found that years between index and repeat EGD basically was associated with the diagnosis of new Barrett's or cancer. Age and index EGD, increasing age was also a factor. Presence of GERD symptoms was also a factor. Increasing BMI was also a factor, and being male was also a factor. Smoking was also associated with being a former smoker was also associated with the diagnosis of new Barrett's or cancer, and years of follow-up after repeat EGD was associated also with increased risk of developing Barrett's or cancer after on repeat EGD. When looking at the effective years between index and repeat EGD by age for new Barrett's or cancer, they found that the diagnosis of new Barrett's esophageal cancer or G-junction cancer risk was highest at the age of 19 to 29 with adjusted odds ratio of 3.92. And then the ratios ranged from, the odds ratios ranged from 1.17 to 1.65. And again, the odds ratio was significantly associated with the discovery of new Barrett's or cancer at ages 40 to 49, at ages 50 to 59, and then 60 to 69. But was not really significantly lighting up at the ages of 30 to 39, with confidence interval between 0.7 and 1.9 for this particular age group. The limitation of this study is that it's a retrospective study, and there is a possibility of Barrett's esophagus and cancer being present but missed during index EGD. The authors do document that photo documentation was scanned in a lot of their records. Also, one thing about the study is that when the patients' charts were manually audited, they did find that some of the codes were entered incorrectly in patients as having new diagnosis of Barrett's or cancer when they actually in fact did not. There's also considerable lag between clinical diagnosis of Barrett's and time of ICD coding when they did a manual chart review. And also this study was conducted using data from the Veterans Health Administration. Therefore, coding practices, BMI and smoking incidence may differ in non-VHA settings, which may affect the generalizability. The main take-home point from this study is that the yield of repeat endoscopy for Barrett's or adenocarcinoma of the esophagus or G-junction increases with time since normal index endoscopy, particularly in younger individuals, and therefore these authors do suggest that prospective studies are required to confirm these findings and maybe requiring a change in guideline recommendations. Next is a study looking at the anticoagulation and effect on survival in patients with cirrhosis and portal vein thrombosis. This is a meta-analysis. Portal vein thrombosis is a well-established event in the natural history of cirrhosis with pooled prevalence of 14% and annual incidence of 10.4%. Contribution of portal vein thrombosis to cirrhosis progression and acute complications is controversial, and previous meta-analysis demonstrated safety and efficacy of anticoagulation in the recanalization of portal vein in patients with cirrhosis. However, the effect on survival is unknown. The aim of this meta-analysis was to compare patients who received anticoagulation versus patients who did not in patients with cirrhosis and portal vein thrombosis. This was a meta-analysis of individual patient data, and they compared efficacy of anticoagulation versus no treatment in improving overall survival and recanalization in patients with cirrhosis and portal vein thrombosis. Individual patient data requested from authors of the included studies, so they could perform an individual patient data meta-analysis, and the primary outcome measure was the effect of anticoagulation on all-cause mortality. After identifying studies through Medline, Embase, and Central, they identified 11 patients 11 studies which could be included in this individual patient data meta-analysis. They contacted these authors to obtain the actual raw data, and they ended up including 5 studies in this meta-analysis, which comprised 505 patients. So of these 5 studies, these were published between 2016 and 2019. One was a prospective study, 4 were retrospective studies. They all included patients with cirrhosis and portal vein thrombosis. And the type of anticoagulation used was either low molecular weight heparin or vitamin K antagonist, which is warfarin, basically. The definitions of thrombosis was provided in 4 of the 5 studies, which comprised either complete lumen occupancy or partial thrombosis. Definition of recanalization was provided in 3 of these 5 studies, with complete recanalization defined as being no residual thrombus, and partial recanalization essentially being defined as any improvement in thickness or length, or at least more than 50% improvement in thickness or length in one study, and in the 3rd study is more than 25% improvement in thickness or length. Follow-up imaging to look for recanalization was either CT or ultrasound. These 5 studies included in this patient data, individual patient data meta-analysis, 205 patients received anticoagulation treatment for their portal vein thrombosis, 295 patients did not. And when comparing the baseline characteristics, the mean ages were 59 in the treatment group, 57.7 in the no treatment group. There were more male than females in this study. The etiology of liver disease was viral in around 50% of the patients. Then alcohol was the most common instance. So it was etiology after viral causes, and then the rest were others. The majority of patients were Child-Pugh class B or C. The mean MEL score was 12 in the treatment group, 13.3 in the no treatment group. Complications of cirrhosis were present in the form of ascites in 53.2% in the treatment group, 55% in the no treatment group. Portal hypertension with bleeding was present in 26.5% of anticoagulation group and 30% of the no treatment group. When looking at portal vein thrombosis severity, partial occlusion was observed in 54.6% in the treatment group, 52.5% in the no treatment group, and then complete occlusion was observed in 45.4% of the treatment group versus 44.4% of the no treatment group. The portal vein thrombosis location was most commonly in the trunk of the portal vein at 82.4% in the treatment group versus 80% in the no treatment group. The main outcome measure was all-cause mortality, and they found that there was a significant a difference between the two groups with lower all-cause mortality rate of 24.9% in the treatment group versus 39% in the no treatment group with p-value of 0.002. When looking at secondary outcome measures, liver disease-related mortality was significantly lower in the treatment group at 9.3% versus 20.3% in the no treatment group with p-value of 0.001. Recanalization rate was also significantly higher in the anticoagulation group at 57.1% versus 37% in the no treatment group with p-value of less than 0.001. Presence of stable thrombus was significantly lower in the treatment group at 28% versus 51.8% in the no treatment group. The remainder of the secondary outcome measures, such as all-cause mortality, patients undergoing liver transplantation and thrombus progression was not significantly different, statistically speaking, between the two groups. The main limitation of this study is the heterogeneity of the included studies in terms of portal vein thrombus severity, the thrombus location severity and recanalization definitions, and the types of anticoagulations used. Studies also had moderate comparability among cohorts. Therefore, there is a possibility that the residual confounding might remain, and caution should be used when interpreting the results for the author state. All the patients were treated either using low molecular weight heparin or vitamin K antagonists, and direct oral anticoagulations were not used in any patients in the included studies. So the take-home point from this study is that anticoagulation reduces all-cause mortality in patients with cirrhosis and portal vein thrombosis, independently of recanalization, but at the expense of increasing non-portal hypertension-related bleeding. So to recap, higher MAP strategy does not confer a survival benefit in critically ill patients with cirrhosis and septic shock, but improves tolerance of dialysis and renal recovery. Higher adverse events indicate the need for better tools to evaluate target microcirculation pressures in these patients. Next, anticoagulation reduces all-cause mortality in patients with cirrhosis and portal vein thrombosis, independently of recanalization, but at the expense of increasing for non-portal vein hypertension-related bleeding. Yield of repeat endoscopy for Barrett's or endocarcinoma of the esophagus and GE junction increases with time since normal index endoscopy, particularly in younger individuals. Just a reminder, us here at Orlando Health are holding a wonderful conference, Florida Live EUS, will be held from August 17th, 19th, 2023 here in Orlando. Please register and join us. If you can, we'd love to see you. All right, our next monthly GI Journal Club is on September 6th, 2023, which is the first Wednesday of September. Thank you so much for joining us. I hope you have a wonderful day, week and month, and I will see you again in September. Thank you so much, everyone.